Hello, everybody. I hope you're all doing well this evening. This ongoing, evolving saga around the regulation, management, and advice regarding medical associate professions, it evolves so quickly. I'm going to try and do more of a job of staying on top of things as new advice, guidance, events happen in the space. I'm a bit too embedded now in what's going on and trying to keep you guys all up to speed with it because it is really complicated. It evolves faster than most people, I think, can keep up with it if you're not clued in with what to read. And so much of this stuff just happens behind the scenes. But as a collective, and that includes doctors and medical associate professionals, so that's physician associates, anaesthetic associates, and surgical care practitioners, there's a lot of weirdness going on. We all have a responsibility to keep abreast of what's going on. And all that means on my side is that the quality or the production value may need to drop a little bit. You'll get things like this so that we can just read stuff because it's quicker for me to produce. I can do it after work, and it means that everything stays timely. But this has been published today by the BMA Junior Doctors Committee. I think it's formally been renamed the Doctors Committee, but JDC. They have published this statement today, and that applies both to junior doctors and to GP registrars. So GP registrars are, I think, junior doctors and have been considered under that bracket. But the point is that this statement comes from both committees. So it's a statement that's been through these two different organisations rather than just coming kind of carte blanche from the JDC. But anyway, BMA JDC and GP Registrars Committee believe that in response to the manufactured workforce shortage, great use of phrasing, the shortage of doctors is entirely manufactured and is not a kind of natural consequence of systems. The number of training places for doctors at both the undergraduate and postgraduate level is known to be short of what we need to meet population demand. So the government has specifically and willfully kept this clamped, which leads to obviously a workforce shortage. If you know you're not training enough doctors, either at the undergraduate or postgraduate levels, you end up with a manufactured workforce shortage. So that is a shortage that the government has chosen to be in place, not one that has developed organically. The rapid expansion of medical associate professionals, which we've already discussed, in both hospital and general practice settings is detrimental to the provision of high-quality healthcare and represents a long-term risk to patient safety. MAPs are not medically trained, do not have a medical degree, and are not doctors. Now, I know there's some quibbling about this idea of being trained to the medical model. It's not really been formally defined what that may or may not mean in terms of the practice of medicine. The GMC's regulatory position, as far as it's coming, is that MAPs do not practice medicine. That needs to be reconciled with the view that these courses are sold and explained as being trained to the medical model. So these two mission statements or position statements need to be reconciled by, I think, the GMC and the Royal College of Physicians, who hosts the Faculty of PAs. But we're not going to get into that debate now. I'm just highlighting that it needs to be explored. Without a clearly defined scope, the rapid expansion of MAPs also undermines the professional identity, knowledge and skills of medical doctors, which itself poses another risk to patient safety. I'm in full agreement with that, and this cuts both ways actually, because of what I've just said about the practice of medicine and who does what within the field of medicine. This is a really critical issue both for doctors, where we have yet to define what is a doctor, what does a doctor do, and you have these new groups coming in that are told that they can do the same roles as doctors and things that doctors have historically done without the skills and the training. But this also cuts the other way, right? We know that professional identity is really, really important for health professions. It's important for professions generally, but there's a massive evidence base for it in health, and the fact that there are these tensions that exist in definitions, roles, regulations around what a PA is or what an anaesthetic AA is or what a surgical care practitioner is and how they relate to the doctors that they work with and are supervised by. This is a complete disaster for the professional identities of those groups, and I think without a clearly defined scope, that is never going to develop properly, which is harmful for everyone. The BMA has called for the reversion of the name of the role physician associate back to physician assistant to reduce confusion for patients and better reflect their role within the clinical teams. Now, this has been set out by the vote that happened at ARM this year, the annual representatives meeting. This was a majority position taken by voting delegates at this event, which sets BMA policy. So once this has been decided, the council and other groups within the BMA have to try and make progress in achieving whatever it is they've been told to achieve. The turning of the name physician assistant into physician associate still remains somewhat murky, and demand for it remains a little bit confusing because associate has its own connotations, and again, this probably needs its own video, but in most circumstances, an associate professional is qualified in the domain of whatever they are an associate in. So the obvious comparison is something like a legal associate who has a law degree and is basically qualified in the same domain. That obviously doesn't apply here, where a physician associate doesn't have a medical degree. They have a PA degree, which is its own thing and different to what is required for a physician. So that obviously creates tensions, and the reasons that I've heard for the name change more centrally come for two reasons. One, that patients were refusing to see PAs essentially because of the assistant connotation. They wanted to see the doctor, and the Department of Health and Social Care actually advised that this name should be changed from assistant to associate to help with regulation. I don't know how much of an interfering role the DHSC actually had with that, but you can see how that causes tensions for doctors when the DHSC seems unilaterally opposed to improving conditions and standing for doctors. To reduce confusion for patients and better reflect their role within clinical teams, MAPs work under the supervision of a named consultant doctor or GP doctor. However, postgraduate doctors are often asked to prescribe medications and request imaging involving ionizing radiation on behalf of MAPs. I can confirm this is something that happens from experience because medical associate professions are not able to prescribe or request ionizing radiation at present. Therefore, if they have seen a patient and that needs to happen, that task needs to go to someone who can do these things. MAPs are not qualified to independently determine whether a prescription-only medication or ionizing radiation is necessary. The BMA's position is that no postgraduate doctor should automatically prescribe medications or request ionizing radiation on behalf of a MAP. If there is an immediate patient safety concern, this should prompt doctor assessment anyway, correct? Which may lead to the doctor deciding to prescribe medications or request ionizing radiation. If there is no immediate safety concern, then the request for a prescription and/or ionizing radiation should be signposted by the postgraduate doctor to the named consultant doctor or GP supervising the PA, AA, or SCP. Now, this is essentially, and I feel slightly vindicated to see it, I made a video some time ago, which I'll link, talking about what should happen if you as a postgraduate doctor are asked to prescribe medication on behalf of someone else. And I basically say this, that in the instance where an associate professional, or not just an associate professional, but anyone else who can't prescribe for themselves, that task needs to go to whoever the designated supervisor is for that person. The reason for this is multifactorial. The first is that every time you write a prescription or you request ionizing radiation, you are taking on a certain amount of risk, right? If I request a CT scan, I need to know what I'm looking for, and I'm weighing that up with the risks and benefits of the additional radiation that person will receive versus the information that I might get from the scan. If I prescribe a medication and ask a nurse or another colleague to give it, I'm weighing up the risks and benefits of what that drug will do in that particular patient and the effect that I'm trying to achieve. And these reviews happen at the point when the drug is prescribed, and a second set of checks will happen actually with our nursing colleagues usually before the drug is given. If you think about the context of a ward round, for example, where an associate professional may have gone round with a consultant and done a ward round and said, the consultant wants you to prescribe XYZ, we still do not blindly prescribe. You do your own checks because your name is on the prescription. Therefore, the risk and the potential for negligence comes to you, even though you are following an order from a more senior doctor. And it's this final sentence which I think should absolutely be the standard. Sadly, it doesn't happen in many departments, but this should be the standard. If there is no immediate kind of life-threatening concern or someone won't deteriorate, if an associate professional or anyone who is not able to prescribe recommends a prescription or requests ionizing radiation, that request should go straight to the named consultant doctor or GP doctor supervising them. Why is this controversial, and what's the reason why this generates tension? It's because most consultants or GPs won't want to do that because it generates extra work for them. And that's why there can be pressure on more junior or early careers doctors to do this kind of prescribing and ionizing radiation requesting because it eases that workload burden on the consultant or GP. As I've talked about before, that is an inappropriate risk burden that is being applied to the more junior doctors here. The GMC would not support the junior in this case if anything went wrong as per their prescribing guideline. And that's why it's so important to see a statement like this, because it means your union will back you in the event that consultants or GPs apply pressure to make these kinds of prescriptions. We reiterate the current guidance as set out in the Gold Guide for Foundation and Specialty Training. What the Gold Guide is, for those who've never heard of it before, it's a very long and very complicated document that sort of sets the standards and requirements for postgraduate specialty training in the UK. So it lays out what everyone's job is, the different organisations, how different processes work, and the standards that should be maintained in terms of meeting benchmarks, supervision, practical day-to-day, things like that. The Gold Guide states that educational and named clinical supervisors should hold a licence to practice medicine and are required to be recognised and or approved in line with GMC recognition and approval of trainers' requirements. As such, it's not appropriate for AHPs or MAPs, MAPs, to formally supervise postgraduate doctors in training. So that's a pretty standard ultimatum as per the Gold Guide. So that doesn't come from the GMC or the BMA. That is a standardized postgraduate training requirement. So your educational supervisor, your clinical supervisor, should not under any circumstances be someone who isn't a trained doctor who not only has a license to practice but is recognized as an approved trainer by the GMC, and that has its own requirements in order to get that status. This then goes a little bit further for GP registrars in a practice setting. So this is a postgraduate doctor who is on a specialty training pathway to become a GP. The BMA GP Registrar Committee's position is that MAPs should not provide supervision or debrief. So after a GP registrar has seen a patient case in GP, their position is that that formal supervision and debrief should be with a fully trained, fully qualified, independently practicing GP. And really, I'm not sure why that would ever be controversial in any setting. That is how postgraduate education for doctors works. The education and training requirements of postgraduate doctors are impacted by the advent of the associate professions. MAPs do not rotate posts or work night shifts, and so have a degree of permanence which allows stronger bonds to develop with their senior colleagues. Doctors can therefore be seen as a wasted investment and are frequently overlooked for training opportunities, and this must stop. Doctors must be trained effectively. This means being prioritised for educational opportunities, even if that means rethinking rotational training. Failure to train the prospective consultants and GPs of the future appropriately will result in an underskilled medical workforce and risks public safety. Now, there's a few things to pick apart here, right? Let's start with this degree of permanence thing, which allows stronger bonds to develop with their senior colleagues. The way that doctors are trained, they often rotate between hospitals, between departments, between specialties. And the reason why that is important is to allow them to continue to develop a very broad base, remembering that what makes the training of doctors different to virtually any other form of health professional is that our training is very broad and very deep. It's built from the ground up, from a kind of first principles anatomy and physiology, on top of which pathophysiology and everything else is built. Which means that even if you don't know what's going on in a particular patient, you have the fundamental skills to be able to work it out and intervene and provide treatment. In order to continue to develop these skills, postgraduate doctors continue to rotate, which is deemed necessary for educational reasons. So they continue to build this very broad base, and that is what's required to become an autonomous decision maker as they become registrars, and work towards becoming consultants. But the problem with this is this degree of permanence thing, where because, for example, a foundation doctor is only in post for 4 months at a time and a core trainee only for 6 months at a time, it's a significant undertaking for a department to train someone in a skill, whether that is lumbar punctures, endoscopy, doing some kind of surgical procedure. And so your doctor will be trained in that skill, but they'll move away in a few months, and then you've got to train someone new. They'll train again, move away. And what the department doesn't have is someone who is permanently trained in that skill, apart from perhaps the very senior doctors that would train, or you might have a dedicated practitioner of some kind. Because of this degree of permanence thing, for obvious reasons, MAPs can then become prioritised for these kinds of training in specialist skills because they're going to stick around in a department for 2, 3, 4 more years. Therefore, they make much more sense to train from a departmental perspective, because then you've already got someone who can do these things, albeit 9 to 5, not on call, usually not nights or weekends. And the tricky thing about using this as a justification for bringing in associate professionals is that it comes back to what we're talking about with manufactured shortages. The fact that doctors rotate is only a thing that is demanded by the way that their training works. So the MAPs in this context are being used to fill a hole or plug a gap that only exists because we continue to move doctors around. But the other thing that I want to highlight is this: failure to train the prospective consultants and GPs of the future. Easy cases are what complicated cases are built on, right? So let's say you have a simple intervention, which might be something like saphenous vein harvesting or something like that for coronary artery bypass. If you take your MAP, or it doesn't have to be a MAP, it could be any other kind of practitioner, such as a surgical nurse practitioner or something, if they are now going to do all of your saphenous vein grafts, because that's what they do and they get very good at doing them, and your surgical trainees are now able to do fewer saphenous vein harvests because you've got your practitioner that does them all, and you can apply this to any simple procedure. It might be lumbar punctures or endoscopy or whatever, or something like regional blocks, regional anaesthetic in anaesthesia, so you've got your anaesthetic associate doing that instead of your trainee anaesthetist doctors. Because they are then less confident and less well versed in the easy cases, this makes it more difficult to build the complex cases on top of those hundreds and thousands of easy cases that they should have done. You should have a pyramid of complexity like this. But we know that graduates from kind of all disciplines in medicine are graduating with fewer case numbers in everything, virtually across the board. Newer consultants that are graduating now are less independently able than the ones that graduated 10 or 20 years ago. And a lot of that simply comes down to reduced case volume. What you really don't want, and what we should not want as a profession, is a situation where medical trainees of any discipline, including surgery, are doing fewer of virtually any case that is valuable for their training. They should be doing these training cases all the time, so that when they become consultants or GPs and they are the independent decision makers that will have to bail people out in difficult cases when their practitioner, their MAP, their trainee isn't able to fix it, your top level person has to be as good as possible. So by not giving people as much case exposure early on, you're de-skilling your eventual top level person at the other end in 10 years, in 15 years. And it's very short-sighted, but it's kind of emblematic of how the NHS is managed as a whole. The question is, how do we meet our targets now? Let's say that we need to get through as many endoscopies as possible, or as many of XYZ procedure as possible. Let's train a practitioner that does nothing but these procedures all day, every day, and bashes through the waiting list. That's fine, and it will look good as far as the targets you're measuring, but you're not thinking about how de-skilled your independent autonomous practitioner will be in 10 years at the end of their training. And one of the really tired responses that we get to this is this idea that there is enough work to go around, there's a bit of the operation that everyone can do, etc., etc. If anyone uses a phrase like that, it tells you that they have simply not been paying attention to the dialogue and what's been going on in this space. That might be true. It might be true in an incredibly idealistic, ethereal way that the senior decision maker involved doesn't really have to deal with. And that is why I think people use this phrase, like there's a bit of the operation everyone can do, it's fine. What that does is it absolves the person who's supposed to be doing the training of responsibility. What they have the responsibility to do is make sure that their trainees are getting the most exposure possible. And if they're not able to do that, then really they should be reconsidering whether they're going to be a trainer or not. Or someone should be reconsidering that for them if they're not able to keep up with that commitment. So just to move on to the second half of this, can PAs, AAs and SCPs prescribe? In the vast majority of cases, they're not legally allowed to prescribe. Yes, so that primary qualification doesn't give them prescription rights. However, a small number of these professionals do prescribe using a qualification obtained in another regulated profession, which is right. So someone who was a nurse or a paramedic prescriber, for example, as part of one of these regulated professions, maintains that ability to prescribe when they become a PA or an AA or an SCP. But it needs buy-in and appropriate supervision and regulation from their employer. The BMA currently opposes the granting of prescribing rights to PAs, AAs and SCPs following regulation as set out in a previous position statement. So there is a misunderstanding that I've noticed actually from some PA students, this is more towards the beginning of their course, that being regulated gives them the ability to prescribe, which isn't technically true. There are two things that have to happen, or that would have to happen, in order for PAs, AAs and SCPs to be able to prescribe, assuming they weren't one of these regulated professions before. The first is that they have to be a regulated profession, right? Currently the GMC are set to do that by, I think, something like mid-2024. But the actual process of how they would be given prescribing rights has not been published, is probably a multi-year ordeal, and it's not been worked out how that would actually be done. It's not the case that they would automatically be able to prescribe and sign off on prescriptions like a doctor would, say. There will more than likely be some sort of postgraduate qualification or training program that they would have to do, as well as, I don't know, a year or two of supervised practice, or something like the V300 non-medical prescribing course. There will more than likely be something additional that they have to do, but I don't think it's been decided what that will actually be yet. It will be a long and drawn out process, that's for sure. What are doctors' responsibilities when prescribing for patients? I think we've kind of already discussed this. You must only prescribe drugs when you have adequate knowledge of your patient's health, and you, this is the really important thing, you must be prepared to explain and justify your decisions and actions when prescribing, administering and managing medications. So that's not just prescribing, that is altering prescriptions that already exist, because it says this phrase managing medicines, and that would include taking people off medication, for example. So let's say you've got a patient who is going for surgery tomorrow, they're going to be operated on tomorrow. You cancel their Clexane, their low molecular weight heparin, because it's the night before surgery, and then they have a PE or a DVT in the early hours of the morning. You've then got to think about why this happened, what were the risks and benefits of removing that low molecular weight heparin, were they actually justified in the context of this patient who we knew to be a bit clotty. Furthermore, the guidance notes that ultimate responsibility for the patient and the consequences of any drug error lies with the prescribing doctor. You are responsible for the prescriptions you sign, and you are accountable for your decisions and actions when supplying or administering medicines, and when authorizing or instructing others to do so. Again, just reiterates what we've discussed before. If you are about to sign a prescription for something, whether that is on a piece of paper or on an electronic prescribing system, that is the point at which all of your safety checks, rationalization, everything else like that should be occurring. If that's something as simple as paracetamol, have you checked the liver function? What is their ALT? What is their body weight? Is there anything else that would make them unsuitable? If you're going to give them ibuprofen for pain relief, what is their kidney function? Do they have metal work? It actually gets quite complicated even for relatively simple medicines. The GMC has issued advice for doctors who supervise PAs and AAs, which provides that if you prescribe based on the recommendation of a PA or an AA, you will still be responsible for any prescription you sign. Be sure that the prescription is needed, appropriate, and within the limits of your competence. And if you delegate the assessment of a patient's suitability for a medicine, you must be satisfied the person you delegate to has the qualifications, experience, knowledge and skills to make an assessment. The BMA's position, so this is a central thing that doctors can reference, the BMA's position that PA, AA and SCPs qualifications do not provide them with the requisite knowledge or training to enable doctors to prescribe safely based on their assessments alone. Doctors should not prescribe based solely on the assessment of a PA, AA or SCP. What does that mean practically for you? It means that if a PA, AA or SCP comes to you as a non-consultant or non-GP doctor that works with them, you should not be prescribing based on their assessment alone. If you're going to prescribe for that patient, you need to be going and seeing and reviewing the patient. And finally, what should I do if a PA or AA asks me to prescribe or request ionizing radiation for them? It's the position of the BMA's JDC and GP Registrar Committee that no doctor should prescribe medications or ionizing radiation solely at the request of a PA, AA or SCP. If there is an immediate safety concern, this should prompt a doctor's assessment anyway, which may lead to that doctor deciding to prescribe or request ionizing radiation. If there is no immediate safety concern, then that request should be signposted by the doctor to the named consultant doctor or GP doctor supervising the PA, AA or SCP. I think it's not massively inflammatory, and the broad principles of what's been laid out here should, to me, be fairly non-controversial. If you are a medical associate professional, working as a PA, an AA or an SCP, if you need these things doing or you want to recommend a prescription or request radiation, then you need to seek out your supervising consultant or GP. Postgraduate doctors, doctors in training, the same goes for doctors. If you are asked by a medical associate professional or, again, another non-prescribing healthcare professional, you either do your own top-to-toe full assessment of the situation or you redirect them, politely and professionally, to their supervising doctor. If the consultant or GP or other supervising doctor gets arsy and difficult about it and threatens to make your life difficult, you now have a very clear statement from the union to protect you. And as ever, flag these things internally to Freedom to Speak Up Guardian and your educational supervisor, because those attitudes are not fair, they're not professional, and they're not safe. And that kind of attitude can only continue to exist if we tolerate it, which we should not. So there we go, that's a review of the statement in way too many minutes. Let me know what you think down in the comments below. Take care.